All right, our next topic is premature rupture of membranes. This is a common complication of pregnancy, and here is our case. 22-year-old prima gravida at 33 weeks gestation comes to the birthing unit stating that 2 hours ago she had a gush of fluid from her vagina. That's a concern. When she complains of a gush of fluid, could she have rupture of membranes at 33 weeks? That's too early. She denies vaginal bleeding, denies uterine contractions, so that's good. Her perineum appears moist to gross inspection, but what is even more concerning, her temperature is 102. If she has a fever in the presence of ruptured membranes, the concern is chorioamnionitis. That's not good. Let's look at premature rupture of membranes. This is what we're going to go through. The diagnostic criteria. We do a speculum exam, pooling positive, nitrazine positive, ferning positive. We've made the diagnosis. Is she in labor? Yes, she is. Do we stop it? No. She's not in labor. How's the baby looking? Electronic fetal monitor. If the electronic fetal monitor is not reassuring, deliver. Does she have chorioamnionitis? Chorioamnionitis, criteria, ruptured membranes in the presence of fever, no urinary tract infection, no upper respiratory infection. You assume it is chorioamnionitis. We're going to give her antibiotics and deliver. If she's uncomplicated preterm rupture of membranes, then we will triage by gestational age. Less than 25, 25 to 35, and 36 weeks or more. Definition. The criteria for preterm rupture of membranes is rupture of membranes before the onset of labor. So we could have pre-viable premature rupture of membranes, we could have preterm premature rupture of membranes, or term premature rupture of membranes. The main distinction is contractions have not yet begun. Risk factors. We used to think that the patient would rupture membranes and then get infected. The evidence is that it is probably an ascending infection which brings about the uterine contraction stimulation. The membranes weaken, and that's why it ruptures. So the sequence is probably infection, rupture of membranes, rather than rupture of membranes and then infection. Now, membrane defects, maybe the collagen is not strong, and we know that patients who smoke have a higher rate of premature rupture of membranes. This is my finger. This is what we call an amni hook. This is an instrument used to rupture the membranes artificially. And you can see it's got a sharp hook on the end there. Have you ever tried to rupture membranes artificially? You put this inside of the cervix, and you try to grab the membranes and pull, and pull, and pull. I can tell you, it is sometimes very difficult to rupture the membranes with a hook like this. If it's so difficult to rupture them, why would they spontaneously then break on their own? And the evidence is an ascending infection, bacteria from the vagina go up through the cervix, in between the uterine wall and the membranes, weaken the membranes, which then rupture. So we have ascending infection, which starts from the vagina, goes up through the cervix, and then weakens the membranes. This would be one reason why a short cervix would make it more likely that you have this irritation that leads to preterm labor. The most common clinical presentation of premature rupture membranes is sudden gush of clear vaginal fluid, and when you look with the ultrasound, oligohydramnios, decreased amniotic fluid. The patient is standing at the stove, cooking, maybe she's at a checkout counter in the store, and all of a sudden, this big gush of fluid all over the floor. Her feet are wet, her shoes are wet. That's pretty impressive. But let's say she says, I woke up in the morning and my panties were a little bit moist. Well, that may or may not be. We do not make a diagnosis visually by looking at the perineum. We're going to have to do a speculum exam. And what we're going to do with the speculum exam is look for pooling of amniotic fluid in the posterior fornix. We're going to take that fluid out and put it on a pH-sensitive paper, nitrazine paper, and it should turn it dark. And then we'll put some of that fluid on a glass slide, let it air dry, and look for a ferning pattern. Speculum exam. And you can see here, positive pooling. Here are the membranes bulging as well. Nitrazine positive. It turns the pH paper dark because amniotic fluid is alkaline. Vaginal pH should be more likely acidic. The glass slide. Here is the ferning pattern. You can see a very clear, distinct ferning. This is probably because of sodium chloride crystals which form on the glass. But you get these three: pooling, nitrazine, ferning. You've got the diagnosis. So, pooling positive, nitrazine positive, ferning positive, that is consistent with the diagnosis of ruptured membranes. We must rule out chorioamnionitis, because if there is an infection which is clinically overt, this patient needs to be delivered. If she has a fever, uterine tenderness, confirmed premature rupture membranes by speculum exam, and no upper respiratory infection, her lungs are clear, we take a urine sample, send it down, there's no white cells in the bacteria, no urinary tract infection. We make a clinical diagnosis of chorioamnionitis. Why is that important? Because this is linked to cerebral palsy. It's one of the risk factors. This baby should not be left in utero. Okay, management. If she has uterine contractions, don't stop labor. If she has chorioamnionitis, we're going to get vaginal cultures specifically for group B strep. We're going to give IV antibiotics. What organisms do you think cause chorioamnionitis? They're normal vaginal flora. They're going to be anaerobes, going to be gram-positives, they're going to be gram-negatives. So we're going to give multiple agents. Typically, we're going to give gentamicin and clindamycin. And prompt delivery, not necessarily by cesarean, if we can get a vaginal delivery, but we need to get this baby out. If she has ruptured membranes, no contractions, baby's doing well, no chorioamnionitis, then we will triage by gestational age. Gestational age is so important because the increase in perinatal mortality and morbidity as we have declining gestational age. Notice here where we look at gestational age on the x-axis and morbidity on the y-axis, the likelihood of respiratory distress in the blue line, patent ductus arteriosus in the green line, necrotizing enterocolitis on the brown line, and intraventricular hemorrhage on the black line. And you can see very clearly, the earlier the gestational age, the more concern there is about morbidity. As you get further and further along, less and less. At what point do we say there's no great risk to delivering the baby? In terms of intraventricular hemorrhage, 33 weeks. Necrotizing enterocolitis, 33 weeks. PDA, 35 weeks. Respiratory distress, 36 weeks. So we can basically say after 36 weeks, it's probably no great benefit to leaving the baby in. This looks at the hazards associated with premature rupture membranes if the fetus remains in utero, if preterm delivery occurs. If you leave the baby in, infection, deformations, oligohydramnios, the fetus can be in all different kinds of positions and it can't move because there's no amniotic fluid there. Umbilical cord can get compressed, and pulmonary hypoplasia if you have rupture membranes before 20 weeks. How about the mother? She can get infected because of immobilization. She can get deep venous thrombosis and psychosocial separation from her family, from her husband. That's traumatic. On the other hand, if you deliver the baby prematurely, what are you looking at? And here we have our alphabet soup. Respiratory distress, patent ductus arteriosus, intraventricular hemorrhage, necrotizing enterocolitis, retinopathy of prematurity, bronchopulmonary dysplasia, cerebral palsy. Not good. So largely, it is dependent upon gestational age. Pre-viable, and let's say less than 24, less than 20 weeks. The big concern is pulmonary hypoplasia. Between 24 and 35 weeks, it's prematurity, and after 36 weeks, it's infection. Let's get the baby out. So pulmonary hypoplasia, prematurity, and infection. Less than 24 weeks, what are your options? The likelihood of survival, let's say 18 weeks, is so low. One option is to induce labor, although that's a tough decision when the fetus is still alive. The other is to send the mother home at bed rest. Why keep her in the hospital? Expose her to nosocomial infections, tell her to come back when contractions start, or if she has a fever. If she is viable but preterm, now we're going to hospitalize her, typically at bed rest. We're going to give maternal steroids, betamethasone, to enhance the fetal lung maturity if she's less than 32 weeks. Cervical cultures, specifically looking for group B strep, and we will give 7 days of ampicillin and erythromycin. Those have been shown to prolong the latent period between membrane rupture and delivery. If she is 36 weeks or beyond, there's no great reason to continue the pregnancy. Just deliver. This picture shows the pulmonary hypoplasia. The lungs are so small. And I've seen women who have had early premature rupture membranes in the hospital for months with her head down trying to keep the fluid in. She goes into labor at 33 weeks, delivers a baby that lives for about an hour and a half, but is unable to survive. Pulmonary hypoplasia. Here you can see the likelihood of pulmonary hypoplasia is almost 100% at 18 weeks. With advancing gestational age, it gets lower and lower, but this is a major concern early in the pregnancy. All right, what have we said? Diagnosis, speculum exam. If she's in labor, don't stop it. If the baby has an abnormal or non-reassuring fetal monitor strip, don't continue the pregnancy. If she has chorioamnionitis, gentamicin, clindamycin, get oxytocin going if she's a vaginal delivery candidate, and get the baby out. If it's uncomplicated premature rupture membranes, less than 25 weeks, induce labor or go home. If she's 25 to 35 weeks, we'll do vaginal cultures, looking for group B strep, ampicillin, erythromycin, and betamethasone if she's less than 32 weeks, and just watch. If she develops a fever or contractions, let her deliver. If she's 36 weeks or more, go ahead and deliver. And that is the end of premature rupture of the membranes.